webinar. My name is Mary Corey, Education Specialist for WorldLinkMedical, and I will be moderating today's event. I would like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser in the lower right-hand corner of your screen. You should see the chat box where you can enter your questions to Dr. Teresa Ramsey. They will be answered at the end of the presentation as time allows. This web conference is brought to you by WorldLinkMedical. We provide evidence-based CME-accredited education in preventive medicine and age management with a focus in bioidentical hormones. And as I just mentioned previously, don't miss our next course, Hormones and Beyond for 21st Century Wellness Medicine, scheduled October 6th through the 8th at the Lead Lodge in Omaha, an all-inclusive resort. Our deadline is September 4th for registering for that event. MedQuest slide. Today's event is sponsored by the educational grant from MedQuest Pharmacy. We are grateful for their continued support in recognizing the importance of patient and prescriber education in the field of bioidentical hormone replacement therapy. They are true leaders in the industry, and we are proud to be supported by them. I would like to introduce Dr. Teresa Ramsey, who is a practicing physician, speaker, lifestyle expert, author of the best-selling book, Healing 101, a guide to creating the foundation for complete wellness, and is a weekly guest at Arizona's top morning television show, Your Life A to Z, as their medical expert since 2007. She has been chosen as one of Phoenix Magazine's top docs for 2 years in a row and was chosen as the Natural Choice Awards winner several times. She has taught leading physicians and many people about the importance of hormone replacement therapy for both quality of life and disease prevention. Dr. Ramsey bridges the gap between allopathic and naturopathic medicine. Please welcome Dr. Teresa Ramsey.
Thank you, Mary. And I hope all of you listeners took advantage of that 10 minutes it took me to get online. I live in Arizona, and I was not thinking of the hour difference, even though I was just in Salt Lake last weekend. So please accept my sincere apology for being late. So we all know, I mean, all of us that have been studying with Neil know that metformin is used to treat not only diabetes type 2, but it's also something we should consider in every patient that has polycystic ovarian syndrome or insulin resistance. And this presentation isn't about that, but since being at level 1, there were lots of participants who were interested in that, so I have a few summary slides only in the very beginning of this presentation, just to catch them up, and hopefully they'll continue studying with Neil with the rest of the levels this year. So there's new and emerging studies on metformin for chronic conditions like cancer and Alzheimer's prevention and treatment. The studies are all new, and most of them are retrospective, observational, so they are weak and yield like varying degrees of consistent outcomes. You'll see this, but it's a very new study with metformin. And all of the interest in using metformin for chronic inflammatory conditions, it stems from the biochemical pathways that are enhanced with metformin, which is what we're going to talk about today. So suppositions rose from this and now are being explored in the literature. So let's just get started. And the beginning slides, well, we'll talk about Pecos first. Okay, so the objectives today, they're not going to include Pecos. Again, that was just for level 1 people. It's to gain knowledge of the suggested evidence that metformin has added to the benefits of the clinical setting, regulating glucose levels, and to develop a deeper appreciation of metformin's benefits outside of type 2 diabetes and insulin resistance in clinical practice through understanding the mechanism of action of metformin on all of our cells. This deeper understanding will assist clinicians in identifying patients that may be a candidate for metformin that may have been overlooked in the past, and we're going to identify risks of metformin therapy as well. Okay, so Pecos, polycystic ovarian syndrome. This is just a summary, and all of this information you're going to get at level 2 when you attend level 2 with WorldLink. So the cause of Pecos is insulin resistance. It's an endocrinopathy. It's not a gynecological issue, as we know. It's the increased insulin levels that lower sex hormone binding globulin production through the liver. When we have low sex hormone binding globulin levels, there's a higher free testosterone, and this is where the hirsute symptoms come from. Yes, the high LH can make testosterone total levels high, but it's the free testosterone where the hirsute symptoms come from. The binding proteins are inversely related to inflammation in the literature, showing that the lower binding proteins that there are, the greater the risk of diabetes, the greater the risk of heart disease. So we want to raise sex hormone binding globulin, and metformin raises binding proteins. It also lowers insulin, lowers LH, and testosterone levels. I know this is really a brief overview, but I want to tell you some statistics that are really important that Neil will drive home. There are 50% of Pecos patients that are obese and 50% are not. 50% have hirsute symptoms and 50% do not. What does that mean? That we're going to miss 90% of Pecos patients. So if we're missing 90% of Pecos patients, and now today we're going to talk about non-Pecos patients, we certainly don't want to miss a patient that can really benefit from metformin. So let's talk about how metformin works. Okay, all of these next few slides are coming from one article that is on the bottom. It's from Life Extension. It's just basically explaining how metformin works, a technical review published in November 2015. So all of this is taken directly from that article. So we die not of old age, but failures of cellular machinery. We know that because we've been studying with Neil for years. These failures should not be thought of as inevitable breakdowns, but instead as reversible elements of aging. One such reversible factor is the enzyme AMPK, adenosine monophosphate activated protein kinase. And scientists are starting to think of this enzyme as literally a suppressor of aging itself. So AMPK is found in every cell, and it's considered our master metabolic switch. The core role of AMPK is to sense the energy cell status at every moment and to trigger responses that maintain the cell's energy at precisely the optimum level. Sounds pretty important. Every cell in our body depends on a steady state of supply of energy, and this energy comes from food. And when it goes through the Krebs cycle or the citric acid cycle, we end up with a molecule of ATP. The more ATP that is present in the cell, the higher the available energy supply in the cell. So we know that when cells lose their energy, they don't function efficiently anymore. So when ATP is broken down and is released, it releases an end product called AMP. And when the cell accumulates AMP and runs out of ATP, the cells start to collapse and die. So this is where AMPK activation is going to come into play. The bottom bullet, activated AMPK in turn increases fatty acid oxidation, glucose transport, and releases additional energy from stored sources, which is, fats and sugars. So I'll say that AMPK also inhibits cholesterol and triglyceride synthesis. It blocks lipogenesis, and it modulates insulin secretion by pancreatic beta cells. That wasn't on here. So high levels of AMPK are naturally high in youth, and they drop with age sharply. And guess what? The modern American lifestyle, which is, overeating calories, the article said nutrients, but to me it's too many calories, and poor physical activity is the worst on AMPK system. And then it's markedly decreased when we consume more calories than we need and are sedentary. So AMPK promotes cellular housekeeping, and it's where the cells consume themselves, recycle their contents, eliminate damaged DNA and misshapen proteins. They can themselves impair cellular function and even trigger cancer. So if the AMPK is not efficient, it's not getting rid of all of the debris in the cells. And as a result, young organisms that have high AMPK activity are at a very low risk of cancer. We know this, and degenerative disorders such as Alzheimer's, which stems from the misfolded or damaged proteins. So it's evident that we should do everything we can to keep our AMPK levels high. And if in this article it says if you don't have a physician that is willing to prescribe or able to prescribe metformin for you, find someone that will. There are, in this article, they did talk about, if you want to know, they did talk about other things that can be used to increase AMPK, natural things. Two of them that they listed one was from rose hips, and the active ingredient was trans-telluroside. Hopefully I'm saying that right. And the other one comes from a Vietnamese herb, and it's the Gynostemma pentaphthalum. That's in the article if you want to look at it. It's at the very end of the article. I know that berberine is also an AMPK inducer. It wasn't listed in this article, but berberine is another one. So this is an article that was published in 2010. It was one of the earlier articles. I think one of the first came out in 2008, suggesting that we should consider metformin for cancer prevention and treatment. So the name of this article, Taking Away the Candy for Cancer. So in 1924, it was first hypothesized that there was a connection between cellular metabolism and malignancy. So way back in 1924, this was being discussed. The signaling pathways controlling metabolism in cancer and their interactions are now being unraveled, and evidence is accumulating that conditions associated with metabolic disturbances like type 2 diabetes increase cancer risk. We've learned this from Neil. We've learned, that, the inflammatory cytokines and visceral fat is going to increase the risk of, chronic conditions, and type 2 diabetics often have a lot of that. So this is not a new concept for us, but this article is going to walk us through the different things they know about why there's a strong connection. Again, it's all about AMPK. This is just reviewing what we just went over. It's a pro-aging signaling pathways when it's deficient. And I'm going to go down to the fourth bullet. Insufficient activity of AMPK allows uncontrolled cell growth, despite the conditions of cellular stress, such as those occurring during tumorigenesis, making AMPK an attractive target for anti-cancer therapy. Okay, so let's go to the next slide. So we know there's a risk between an increased risk of cancer from diabetes type 2. And the bullet number 2, besides the numerous conditions associated with hyperinsulinemia and type 2 diabetes, including physical inactivity, obesity, and high saturated fat diet, these are all independent risk factors for cancer, and they're all independent risk factors for lowering AMPK. There is a large overlap in causes and consequences of these conditions. However, there is evidence from case control and prospective cohort studies that diabetes type 2 is an independent risk factor for cancer. Okay. So diabetes and cancer mechanisms. The pathophysiological mechanisms responsible for the development of type 2 diabetes, insulin-resistant hyperglycemia, and the resulting hyperinsulinemia are all associated with cancer risk. Although insulin-responsive tissues, such as skeletal muscle, become insulin-resistant, it's the epithelial cells that remain relatively insulin-sensitive, which is responsible for most of the cancers. Furthermore, there is evidence from animal models that hyperinsulinemia in the setting of insulin resistance, as well as exogenous insulin injections, increase cancer risk. So we have inflammation and the adipokines. So inflammation provokes insulin resistance. We know that. The third bullet, in adiposity, non-esterified fatty acids compete with glucose as a metabolic fuel, inducing insulin resistance, and this leads to reactive oxygen species. And the majority of inflammatory mediators are known to increase insulin resistance, leading to an increase in insulin levels, contributing to inflammatory response. So inflammation is an independent risk factor for developing cancer. So metformin as an anti-cancer agent. So it's about the AMPK induction, right? It's the beneficial effects expected from the reversal of hyperglycemia, insulin resistance, and hyperinsulinemia, and their mitogenic effects have indeed been demonstrated in vitro and in vivo models in cancer. Reported mechanisms of actions of metformin include reduced insulin-like growth factor, that's IGF-1, and in some of the articles, they say it lowers IGF-1 but increases IGF-PB3, which is where we all know the protection comes from. Lowers insulin, HER2-mediated signaling, inhibition of mTOR signaling, and inhibition of angiogenesis and induction of cell cycle arrest and apoptosis. Okay. So, cell growth inhibition. Metformin inhibits the growth of various types of cancer cells, both in vitro and in vivo. This inhibition is both dose and time dependent and can potentiate the effect of chemotherapy. We'll review some of those articles in October in the conference coming up. Growth inhibition is partially abolished in the presence of small interfering RNAs against AMPK or AMPK inhibitors, demonstrating the pivotal role of AMPK in cancer. So liver kinase B is essential for the activation of AMPK in metformin. And there are some people that have poor expression of this downstream enzyme to AMPK, and people who have this will not respond to metformin. I'm looking into measuring this level. It's really used in research, but I think it would be helpful for all of us in clinical practice to be able to measure LKB1, especially if a patient's not having a response to metformin or is having a negative response to metformin. Metformin does not inhibit cell growth in LKB1 null cells, which is what I was just explaining, confirming the requirement of it to have metformin work. Okay, so mTOR, the mechanistic target of rapamycin. The majority of the growth inhibitory effects of metformin are mediated through this signaling. Activation of AMPK by metformin results in phosphorylation and stabilization of tuberous sclerosis complex, which integrates regularity inputs and transmits them to mTOR. And mTOR is what's been studied for in a lot of cancer models, and these regulatory inputs include oxygen-dependent signals and growth factor-dependent signaling pathways such as P13 kinase and MAPK signaling. So I have this. So these are enzymes that are, I have it written down for the P13 kinase one, because they have all of these enzymes that they're talking about, because I'm not a cancer specialist, but they induce apoptosis or cell cycle arrest. So metformin is inducing all of the different enzyme pathways that you're going to hear about in this article. mTOR phosphorylates downstream mediators leading to the regulation of cell cycle progression, cell growth, and angiogenesis. So HER2 is overexpressed in approximately 20% of cancers and is a major driver of proliferation in cancer cells. Metformin reduces HER2 protein expression in human breast cancer cells through inhibitors of mTOR. After this article, we're going to talk about triple-negative breast cancer, so you'll see a little bit more about that. Interestingly, at lower concentrations, metformin blocks HER2 kinase activity. Metformin can prevent resistance to HER2-based therapies by inhibiting the upregulation of survivin. And in a similar way, mTOR inhibitors can overcome Herceptin or chemotherapy resistance. And interestingly, AMPK activation allows cardiac cells to survive the cardiotoxic effects of anti-HER2 therapy. And these mechanisms indicate that combinational therapy with HER2-targeted agents and metformin could have synergistic effects. I'm going to back up one slide. Yeah. So, it's talked about in the next article, but we know that triple-negative cancers are the most difficult to treat. So if we have something that's going to make a big difference, like metformin, I think that we all should consider it. So angiogenesis and inflammation, of course, we know that these two go together. So inhibition of angiogenesis is another proposed mechanism of metformin's effect. And metformin can attenuate angiogenic stimuli in the serum of Pecos patients with insulin resistance and decreases the level of vascular endothelial growth factor in obese diabetic patients. So it's multifactorial metformin on cancer. In addition, in vitro studies have shown inhibition of angiogenesis and inflammation by metformin through inhibition of the mediators listed here, and possibly through inhibition of mTOR signaling. So apoptosis and P53. So P53 is a tumor suppressor gene. It's involved in DNA damage, repair, and cell cycle regulation. Interestingly, though, in adipose tissue, P53 is involved in the development of insulin resistance through the induction of getting older. AMPK can phosphorylate and activate the tumor suppressor P53, leading to the inhibition of cell division and induction of apoptosis in cells that encounter low nutrient conditions. This mechanism can lead to apoptosis in P53 proficient cells and induce re-expression of functional P53 cells in the low levels of wild-type P53 as well. But in activation of AMPK by metformin also enhances apoptosis induction in the P53 deficient colon cancer cell lines. This is possibly due to a metabolic conversion that P53 deficient cells are unable to execute, making metformin selectively toxic to these cells. Apoptosis induction by metformin is an interesting mechanism, although the conditions under which it occurs need to be determined, since not all studies describe apoptosis induction by metformin. And you'll see this at Hormones and Beyond, that not all studies are saying, having the same outcomes. P53 expression in adipose tissue is involved in the development of insulin resistance, and therefore metformin-induced P53 expression may be expected to increase insulin resistance. Wasn't expecting that, but non-apoptotic effects of metformin on P53-induced insulin resistance have, however, not been described, and if present, are likely to be masked by a larger reduction in insulin resistance due to improved signaling through insulin receptor. So even though it may make it worse, that may not even matter in the effect that metformin has on the insulin receptor. And again, it's not really been described. And then cell cycle arrest. So induction of cell cycle arrest is another potential mechanism of metformin's anti-cancer effect. In cancer cell lines, metformin treatment resulted in the dose-dependent inhibition of proliferation through a decrease in cyclin D1 protein expression. Genome-wide analysis have also demonstrated that metformin suppresses numerous mitosis-related gene families, including tubulins, histones, and aurora kinases. And further studies are needed to determine the importance of this mechanism in a variety of human tumors, since metformin-induced cell cycle arrest requires the presence of cyclin-dependent kinase inhibitors, which are lost or downregulated in many cancers. So how important this is, we do not know yet. We're going to look at some preclinical studies, population studies, and prospective studies, all listed in the same article because it's a review article. Studies in rodent models confirm that metformin induces AMPK activation and can inhibit tumor growth and prevent or delay tumor development. And so preclinical studies are in animals, right? So metformin significantly reduced the stimulatory effect of a high-energy diet on the growth of lung cancer xenografts in mice as compared to placebo. In carcinogen-induced rodent models of colon and mammary cancer, metformin delayed tumor growth. And metformin also increased the lifespan of mice carrying the HER2 oncogene by decreasing the size and incidence of spontaneous mammary tumors. These limited preclinical studies support further development of metformin as an anti-cancer treatment, but further studies are essential to clarify the most promising settings, identify potentially synergistic effects with other anti-tumor agents, and predict adverse effects. Okay, so now some population studies review. 3 population-based studies have suggested that metformin decreases the incidence of cancer and cancer-related mortality in diabetic patients. Evans et al. Showed that the risk of cancer was reduced in patients with diabetes type 2 receiving metformin with an odds ratio of 0.85 for any metformin exposure versus no metformin exposure. And in the same population, new metformin users were at a lower risk of cancer than the matched controls. Landman et al. Showed that metformin use was associated with lower cancer mortality compared to no metformin use, and that the effect was dose-dependent. Most of the studies used a dose of 1,000 milligrams BID. Balker et al. Showed that cancer-related mortality was lower in patients with diabetes receiving metformin compared to patients receiving sulfonylureas or for insulin. And unfortunately, there was no untreated control group, so it was not possible to determine whether metformin reduced cancer risk or insulin increased cancers. Recent meta-analysis, however, do not indicate a carcinogenic effect of insulin, suggesting a protective effect of metformin. There are some that suggest insulin administration is carcinogenic, although many confounding factors complicate the interpretation of these studies, including the severity of the diabetes and other reasons determining metformin use. They suggest an anti-cancer effect. Okay, so now some retrospective clinical studies. So chemotherapy response rates in a group of 2,500 people treated with neoadjuvant chemotherapy for early stage or locally advanced breast cancer. They found 157 diabetic patients metformin use was an independent predictor of pathological complete response, with 24% of metformin users achieving pathological complete response, which means no tumor detection after chemotherapy before surgery, compared to 8% in diabetic patients who did not use metformin. So 24% compared to 8% is a pretty significant number. Insulin use decreased the PCR rate in diabetic patients not using metformin, while there was no influence of insulin in metformin users. Okay, this suggests metformin reverses the negative effects of insulin use on the PCR rate in diabetic patients using insulin, while increasing the PCR rate in diabetic patients not using insulin, so a dual protective mechanism. And unfortunately in this study, though, no information was available on glycosylated hemoglobin levels or other parameters of diabetic control, and it is possible that improved diabetic control due to metformin rather than metformin itself increase the PCR rate. And that's the problem with retrospective studies, is we just don't know the details, and they are suggesting that, you know, moving forward with all the information we know, that, you know, double-blind placebo-controlled studies start. Although metformin treatment did not influence overall survival in this small study, PCR is a recognized surrogate endpoint for survival in neoadjuvant studies, and these impressive results have led to a huge interest in metformin as an anti-cancer agent. So conclusion, there's a large and rapidly expanding body of evidence from in vitro and in vivo models of carcinogenesis supporting the potential efficacy of metformin as an anti-cancer agent, and this is supported by population-based studies and retrospective analysis of clinical studies. It is important that despite the previous clinical experience with metformin, early clinical trials are well designed, incorporating both safety endpoints and translational research to identify appropriate biomarkers, we said. And the complex interactions between tumor metabolism and growth are rapidly being elucidated, and metformin may prove to be a non-toxic, inexpensive drug which can modulate these tumor stimulatory pathways. And this was the article, again, that we saw in the beginning. So all of that information, if you want to get this article, is summarized, and all of the references are there for you. So now this is the article that I wanted to review on triple-negative breast cancer, simply because we know it's the worst type of breast cancer that women can have, the hardest to treat. This is a very impressive article on metformin and triple-negative breast cancer. So triple-negative breast cancer is more frequent in women who are obese, have type 2 diabetes, and in young women of color. These cancers do not express receptors for estrogen, progesterone, or HER2/neu. We know that. And these data suggest that aberrations of glucose and fatty acid metabolism signaling through EGFR and genetic factors may promote the development of triple-negative cancers. The anti-type 2 diabetic drug metformin has been associated with a decreased incidence of breast cancer, although the specific molecular subtypes that may be reduced by metformin have not been reported. Our data indicates that metformin has unique anti-triple-negative breast cancer effects both in vitro and in vivo. It inhibits cell proliferation, colony formation, and induces apoptosis via activation of the intrinsic and extrinsic signaling pathways in triple-negative breast cancer. And at the molecular level, metformin increases these markers and induces PARP cleavage in dose and time-dependent manner. And so these data are in stark contrast to the previously published biological and molecular effects of metformin on non-triple-negative breast cancer, so estrogen, progesterone positive, HER2/neu positive breast cancer types. So this is a different study. You know, looking at triple-negative is very different than looking at non-triple-negative breast cancer. So nude mice, adenopathymus bearing tumor xenografts of triple-negative Lyme treated with metformin show significant reductions in tumor growth as compared to untreated controls. Metformin pretreatment before injection of the cells resulted in a significant decrease in tumor outgrowth and incidence. So saying that, you know, we take it before we get cancer and then we get cancer, we have better results. Given the unique anti-cancer activity of metformin against triple-negative disease, both in vitro and in vivo, it should be explored as a therapeutic agent against aggressive form of breast cancer. And in this study, they examine all 4 triple-negative cell lines. Okay, in the short term, cell proliferation, MTS assays, metformin inhibited the cellular proliferation of all 4 breast cancer cell lines in vitro in a dose-dependent manner with the IC50 less than 5 millimeters in 3 of 4 triple-negative lines. This is lower than what they previously reported in non-triple-negative breast cancer. So they're seeing a deeper reduction compared to non-triple-negative breast cancer in this study. In long-term, 14 days, clonogenicity assays, metformin showed bioactivity at even lower concentrations. So metformin blocks cell cycle progression and selectively induces apoptosis via capsase activation in triple-negative breast cancer. For me, not being, an oncology specialist, it is amazing to me to see all of the different enzymes that have been studied. Like, they really have looked at so many different pathways that lead to cancer and are able to show exactly what metformin does. We saw that in the previous article. We're seeing it here as well, which really was surprising to me. Metformin blocks cell cycle progression and selectively induces apoptosis via the caspase activation in triple-negative cancers. And then the intrinsic and extrinsic apoptosis pathways are activated by metformin, and the next paragraph just describes the difference between the two. Metformin reduces the level of cyclins and inactivates EGFR and downstream signaling in triple-negative breast cancer. Metformin inhibits and prevents tumor growth in nude mice bearing triple-negative cells. We saw that already. So their summary, what they're saying is that we and others have shown that metformin suppresses proliferation of HER2 overexpressing breast cancer cells via significant reduction of HER2 expression at higher concentrations and inhibition of HER2 tyrosine kinase activity at lower therapeutic concentrations. And in comparison, I mean, the articles that we'll talk about at Hormones and Beyond are going to be more about the more common breast cancers, the estrogen, progesterone positive, HER2 positive. The reason I showed this, and even though this is an introduction, I'm just kind of like wetting your palate to get an idea that we need to start thinking about metformin for prevention and treatment, is using this article I thought would be really helpful because, again, we need to help these women. And if metformin can do it, we're going to be the doctors who know that we can. What I will do, just in the interest of time, is we can send you these slides, and you can read this slide on metformin and prostate cancer. We're going to talk about that again in Hormones and Beyond. Let me go to the next slide and show you that of course, there's always going to be limitations right now because there aren't, great studies available. But the studies that show how metformin works, I think, are really important to show you. But when we see articles that say the worst type of cancer can be helped and prostate cancer is also benefited by metformin, that when we'll discuss these in detail, and even though these aren't conclusive, they're suggestive. And in clinical practice, I'm not sure how many of you use metformin. I use metformin a lot. And I would say that more patients tolerate metformin than don't. There are GI side effects that many patients can get through. But because it's, to me, a benign drug, we're going to go over risks in a moment, but because it's primarily a benign drug with significant benefits, I would encourage you to think of it more in patients that are at high risk for cancer. There's another slide that I will, I'm going to skip this, have you review, and that slide is on Alzheimer's, memory loss. But this I'm just going to read on the prostate cancer. These are the first clinical data to indicate metformin use may improve prostate cancer outcomes, and especially prostate cancer resistant therapy, castration resistant. Okay, so the neurodegenerative diseases, and I know that it was my fault that we're not able to go over these because of the time, but I'm happy to send you all this PowerPoint, and do come to Hormones and Beyond because we'll talk about these as well. And basically this study was saying that metformin should be considered for the prevention of Alzheimer's. So I wanted to get to some side effects and risks of metformin. So these are common side effects. Of this list, the ones that I see the most are diarrhea, and in the patients that experience diarrhea, most of the time it's because they're eating gluten. People must avoid gluten for metformin to work efficiently, and I take it myself. If I'm going to be exposed to gluten, I skip that dose to protect against the GI side effects. Gas I do see as another side effect. Inadequate B12. Well, metformin depletes B12, so we must take B12 while we're on metformin to avoid deficiencies. And weight loss I do see as a result of taking metformin. So those are the common side effects. The infrequent side effects are listed here. I really don't see any of these. I haven't. Indigestion, yes. Constipation, no. It's more loose stools that I will see. And then the rare side effects, of course, we have to be careful of as well. And lactic acidosis, there's a slide I'll show you from metformin that talked about lactic acidosis in their literature. This is just, I won't go over this whole thing, but the European Medicine Agency in 2016, in October, suggested that we consider giving metformin to patients with a GFR as low as 30 and to 59. And on the next slide, you'll see the FDA has agreed and has now updated the guidelines for giving metformin to patients with renal failure. And then lactic acidosis, this is from Metformin Post. Marketing cases of metformin-associated lactic acidosis have resulted in death, hypothermia, hypotension, and resistant bradyarrhythmias. So just be aware of that. Of course, we're going to be monitoring our patients closely. And I've not seen anything close to that. I have seen where even 500 milligrams twice a day in some sensitive patients will lower their blood glucose levels, but I have not seen lactic acidosis. And so we will be talking more about this October 6th through 8th in Omaha on Hormones and Beyond for the 21st Century Wellness Medicine. So I would like to open to questions. I know that that was fast, and I just hope you got the general idea that there's a lot we know about what metformin does, starting with AMPK and then all of the individual measurements in the cancer studies. And to me, it's a very exciting time, and I think more and more research is definitely going to emerge. So please come and listen to us at that time. So we have 5 minutes, and I would like to take any questions. Okay, so I see this question, and I was presented this question earlier, so I did have time to look it up. And the question is, can metformin be associated with sarcoidosis and autoimmune disease? And there wasn't any literature on it. Yes, there was anecdotal evidence I did see. And the only thing that I could think of that might have been the reason that your patient on metformin developed sarcoidosis, and that was that there is a link between B12 deficiency and sarcoidosis, and maybe the patient wasn't on B12, I don't know. The other thing is maybe the patient doesn't have the LKB1 enzyme, which is essential for metformin to work. So that's the only thing I could, think of. And is there a negative impact on gut microbia? There is not a negative. There's actually a positive. And if you want, I can send you that article that talks about it increasing a specific strain that protects the mucosal lining of the intestines. But there was no data on it in worsening it. And metformin and methylation, I don't know of any studies on it, but because B12 is essential to be taken, I would assume that there may be a methylation issue. But I did not see any articles on that. And what can we recommend to patients who are having GI problems with metformin? So you want to really start slow. And if I start with one tab with one meal a day and the patient's experiencing symptoms, I do not increase them because the optimal dose you want to get to is 2 tabs twice a day of 500 milligrams. Some patients I've had to start with half a tablet. What I have noticed in GI problems is that the longer patients take it, the less the symptoms become. So they adapt to it, and the symptoms seem to improve. There are some patients that can't tolerate it. I have tried helping them with enzymes and large meals, but there are just some people that cannot tolerate metformin, unfortunately. We would have to consider other options at that time. So I think that's all the questions that are coming through so far. And I want to thank you for your time. Please accept my apology. Again, it's not like me to be late for anything. I do appreciate you attending, and I look forward to seeing you again sometime this year. Oh, there's 2 more questions. Sorry, I'll wait, Chris. Berberine. So I've not seen a study comparing berberine and metformin. I've not used berberine with metformin. There was a time when we couldn't get berberine, so early on in my practice I kind of forgot about berberine, but it is an AMPK activator, so you can certainly use berberine, especially in patients who are metformin sensitive. Yes, I'll be at part 2, and I'm going to be at all levels this year, so I'll be at part 2 in September. I'll see you there, Barbara. So it looks like that's all of the questions. You can email me any questions if you have that come up after this. And again, because we had to rush through some of those slides, I'll be happy to send you, WorldLink can go ahead and send you the PowerPoint to read those over. So thank you very much. Enjoy the rest of your day and weekend. And I'm honored to be part of WorldLink and teaching with you. Bye-bye.
Thank you, Dr. Ramsey. I hope our listeners enjoyed it as much as I did. Our next webinar is scheduled on Tuesday, September the 12th with Dr. Rosier, who will be discussing new testing and laboratory values for progesterone. Thank you again, Dr. Ramsey, and everyone who joined us today. Have a wonderful rest of your day. Thank you.